azoospermia, the first thing you need to do is check the volume and check whether fructose is present. The importance of fructose, the fructose comes from here, the seminal vesicle. If fructose is absent, it either means that there's an ejaculatory duct block, or it means that the ejaculatory duct and the vas both are absent. On the other hand, if a man has a block in the epididymis or the vas, fructose will still be present. So this would be a typical case. Azoospermia, low volume, fructose negative or fructose quantity not sufficient. And on examination, the vas are not palpable, hormones normal, no further evaluation is needed. If the vas is palpable, it's ejaculatory duct obstruction. If the vas is not palpable, it is congenital bilateral absence of the vasa deferentium. Most likely diagnosis will be CBAVD. You do not need exploration to establish that diagnosis. You do not need a biopsy to prove spermatogenesis is usually present. You will need genetic testing, not karyotype, not YQ deletion. In vas aplasia, you need to look for cystic fibrosis transmembrane regulator gene mutation, and the treatment will be epididymal sperm aspiration and ICSI. If there's ejaculatory duct obstruction, we will do a transrectal ultrasound, and at the time of TUR, we will do vasography. Now, the second kind of patient is one where there are azoospermia, fructose is present, volume is good. Now, here the clinical examination becomes very important. If the testis is good, epididymis and body is turgid, but is palpable, hormones are normal, most probably this is a case of obstructive azoospermia. And if the surgeon is pretty confident, either he will do a single biopsy to just prove that it is obstructive, or he will directly expel the patient to treat the obstruction in the epididymis by doing a vasoepididymal anastomosis, or the patient may say, I don't want surgery. He may directly do an epididymis sperm aspiration, freeze the sperm and proceed for ICSI. Now, which is better? We already spoke about it. Younger patients or patients on a budget, VEA, vasoepididymal anastomosis to correct the obstruction, is a better choice. If the couple is older, under lot of social pressure, VA has been done, has failed, or VA not possible, then IVF ICSI is a better choice. We look at all these parameters and decide. Now, here's the other type of azoospermia, which you will often see in the clinic. Good volume, azoospermia, fructose positive, but the testis is very small. Epididymis is flabby, FSH is high. This is obviously a case of testicular failure. You do not need to do a testicular biopsy here to prove that it is testicular failure. Here you're going to discuss with the patient that, look, by examination, by your hormones, I know you have primary testicular failure. You have two choices. Either you can go in for donor sperm or adoption, or the second choice is that we can try ICSI if we are able to get some from your testes. If the patient says, no doc, too expensive, I want to go in for donor sperm, then in this case you don't need any further evaluation. You don't need a genetic test, you don't need any other hormone testing, you don't need a biopsy. It's clinically obvious testicular failure, going for donor sperm, end of story. If the patient of testicular failure is doc, I would be interested. Then you have two ways of approaching the patient. First is to do a trial TISA, micro TISA. And if you freeze the sperm and then do ICSI. The advantage of this approach is if you don't find sperm, the wife doesn't have to be stimulated. The disadvantage is that sometimes the cryopreservation fails and the sperm do not survive cryopreservation, and then you have lost the chance. If the patient says, doc, any chance, money not an issue, 1% chance want to take, then in such cases, we will stimulate the wife, and on the day of ovulation or 1 day prior, we will do a TISA, micro TISA, do our best to find sperm, and if sperm are not found, then comes the patient whether he would like us to keep donor sperm on standby. And the final presentation which you will see again in many cases, aospermia, good volume fructose present. Testis size is reasonable, FSH is normal but high normal. Epididymis is not turgid. So you're not sure that it is obstructive, probably non-obstructive, but it could be either way. In such a case, one option would be to again treat him like non-obstructive, but do a trial TISA first. If the trial TISA shows many sperm, then you know that this is obstructive. And either you can do ICSI with the frozen sperm, or you can take him for microsurgical reconstruction, or directly the patient may go in for IVF ICSI. So a lot will depend on, in these cases where you're not sure whether the patient can afford IVF, whether you're considering VA, do you have IVF, can you do sperm freezing? And based on that, you may do 3-4 needle biopsies and then decide whether to do a VA, whether to do nothing at all, or whether to do IVF. Now, I've rushed through this. Obviously, it's complicated. Half of this you've understood, half if not, but you've got some idea of the flow chart. Maybe we can clarify this further during the question-answer session. So I think I've now 2 minutes left, correct, Neil?
Yes.
12:40. 2 minutes. Would you like to see one video?
Yes. You can play one video.
So I'll show you a video on microtest. And these are videos that have been compressed so that they can be shown over the net. The quality will suffer a little, but the transmission should be good. Let us see if you can see it. Let me again try and maximize it.